primarily in HIV care since I don't know when you started, but more than 20 years. Charnell, maybe 25 years for Charnell and 20 for Ayanna. They've worked in the Pediatric ACTG network when it became the Impact network, and then in the ATN network, and then on various pharmaceutical studies, and also on most recently on the COVID study initiative with the Novavax study. So they're very experienced nurses with a lot of experience in HIV and drug studies. So thank you for being here today.
Thank you.
Thank you.
I guess we can go ahead. So
Yes,
our
please.
topic,
Thank you.
okay, thank you. Our topic is vulnerability and disparity in research. It's from research nurses' perspectives.
So our objectives will be today how to identify and protect vulnerable groups, acknowledge disparities in research, awareness of distrust in research, and how to develop trust and prevent disparities in research.
Now, according to Merriam-Webster, the definition of vulnerable is described as capable of being physically or emotionally wounded, and 2, open to attack or damage. So when you think about it, we all are vulnerable. Vulnerable groups can be described using 2 methods.
One way to identify vulnerable groups is to use a categorical approach. These are examples of groups that fall within the categorical approach. They include pregnant women, children, minors, diminished mental capacity, prisoners, educational disadvantage. These people are at increased risk for being influenced or coerced and are considered vulnerable populations in research. We also have other groups that are considered in the vulnerable categorical approach are elderly, LGBTQ+, and minorities.
Another way to identify vulnerable groups is to use a contextual approach. Now, this describes situations or conditions in which individuals may be vulnerable. An example of the medical vulnerability category may include people who have serious health conditions for which no satisfactory standard treatment options are available. So you might think of the terminally ill. This person may feel obligated to participate in research to get the treatment. Another example of this may be due to the doctor-patient relationship, where the deference could occur out of a fear of offending the authority figure and incurring retribution from a genuine desire to please the respected other. Being economically disadvantaged presents another vulnerability. This person could make statements like, well, I really need the money and the free health care, so
Charnell,
I'll participate. Yes.
Ayanna, I'm sorry. I'm trying to offline ask people if they're seeing the slides, but I'm seeing your computer top, not your slides. Is everyone seeing the slides and not the screen?
I see the slides.
I see the slides.
Okay, there's something wrong with my computer. I'm sorry I bothered you.
Yeah, it's okay. I'm sorry. So this person may say they need the money because they're economically disadvantaged or the free healthcare. So then they agree to participate in the research. But without the vulnerability, they may not have chosen to participate in the research. We mentioned compensation but it's probably inappropriate to keep emphasizing it, saying something like, dangling a carrot, like, don't forget, you get $100, because that puts the vulnerable person in a situation of being pressured. Now, the institutional vulnerability includes people who are under the formal authority of others who might have different values or goals and priorities than the potential research participant. And they may not be able to make a truly free decision about participating, and may be at risk for exploitation. Examples of this include prisoners, someone in the military may come to mind, any person whose relationship with a superior might make it difficult for him or her to say no. So you also think of maybe employees or students, for example. Now, the cognitive and communicative vulnerability, they kind of blend together, but they broadly encompass people who have difficulty comprehending information and making decisions about participation. For example, someone with a communicative vulnerability would be someone with who's hard of hearing or deaf, or someone who has a language barrier. Now, the person who is deaf or hard of hearing may not have a cognitive vulnerability, just a communicative one. So we have to be careful about assuming that just because they're deaf or hard of hearing, they're not going to be able to understand the research. The same thing goes with a person with a language barrier. This can be both a cognitive or communicative, but in some instances, it's only the communicative barrier. And once we get past that, the person is able to participate if they choose to. Another example would be someone who has delayed or challenged learning. For instance, someone with ADHD, some people with autism, or someone who might be illiterate. In this case, maybe a witness would be present to hear and advocate for the person. And the social vulnerability includes people who belong to an undervalued social group. They are considered less important. But this is just a function of the social perception of a certain group. And this includes stereotyping and can lead to discrimination. So such groups that come to mind would be minorities, or maybe someone from the LGBTQ+ population. So we've identified some vulnerable groups and described what makes them vulnerable. Now let's take a look at how to protect them.
How to protect the vulnerable groups. They are in a vulnerable position. They may feel obligated due to the pre-existing conditions and with the researcher, and they may feel that they don't want to let that person down. Be aware of the vulnerabilities, which we discussed earlier. Delay enrollment. If the participant has many life challenges, which can prohibit their successful participation. We have a prime example that recently happened within our clinic. We had a potential enrollment. Their daughter was in the hospital and we delayed enrollment. And unfortunately, the daughter passed away. So another delay or possible may not be enrolling. So, those are life challenges that happen. So delaying the enrollment at that time. And you can be revisited at a later date as well. You may have lack of housing, lack of access to a telephone, maybe work schedules may prohibit the delayment in enrollment as well. You may need to explain the research in a easily layman's terms. You may want to have the consent, length of the consent shortened. And also, we offer consisting 3 to 5 questions to assure that they have an understanding of the research. Like we do a quiz. So during the consent process, we may ask them, do you understand? Do you have any questions? Because ultimately they are part of the research team. Also, during the visit, you may want to offer an advocate. Keeping in with HIPAA disclosure, if requested, they may, with the advocate, they may be elderly, minor, young adults, or someone who just needs more extra time with the process in that day. The advocate can be there all throughout the whole day, depending on if they have frequent blood draws, PKs, or complicated procedures. Also, educate the staff, the clinic staff, general office staff, for general knowledge of the study. Basic information can be addressed or referred to the research team for detail. Someone may feel comfortable, so when they call the clinic and they're asking, for example, about the Ebony study, and they say, the staff will say, oh, yes, I know about that study. Let me connect you with someone that can answer those questions, rather than saying, I never heard of it, please hold. Also, offer a professional interpreter or a sign language interpreter, not family, but someone that is objective, that can help and understand, help them understand the study, and especially for the deaf participants. Also offer snacks. For example, through our COVID vaccine study, we had a gentleman that came in and we heard their stomach gurgling, and we asked, are you hungry? And it was like, yes. So we offered them something to eat, and they was very grateful and left smiling. And also allow flexibility within research allowances. This is the real world, and we want to make sure that they're flexible, like I said, with job schedules, and most research teams will understand the reason, and is well documented. Point is, we have to be cautious and aware of the vulnerabilities when presenting research. The power between the researcher and a participant must be recognized. So we have a poll question for you.
Yay.
And I'm going to launch it. Okay, Charnell.
So, sure. This is a true or false. Two approaches to identifying vulnerable groups are categorical and rhetorical. You have a few minutes, or 1 minute, actually.
Yes, 1 minute.
We had Jeopardy music, but we said no.
Right. I don't know if I should sing. Dun,
We
dun.
can't, yeah, that might, yeah, I don't know. Okay, think
Okay, we've got
everybody's
10
got it.
seconds left. Okay, I'm going to end the poll.
Okay.
Share the results. Okay,
So, yeah. Go ahead, Ayanna.
67% said true and 33% said false. So the answer
Correct.
is false.
False. Yes, it's contextual. So categorical and contextual are the two approaches that we discussed. Okay. Thank you. Take that away. Going to the next slide. So let's look at disparities in research. These are just four that we decided to discuss: economic, racial, gender, and educational, but there are others, as we all know. Now, let's go back to a definition. According to Webster, disparity is a social or economic condition that is considered unfairly unequal. So there is a lack of equality. This is different from when you have two teams playing a sport. One is better than the other. One gets the trophy, the other doesn't. We're assuming that was a fair competition, and so one was rewarded and one wasn't. With disparity, it's an unequal balance. So one group is treated unfairly. And disparities in research are no different. It's just, like I said, treating a group differently based on perceptions about that group. So economic disparities, an example would be maybe research that happens in underdeveloped countries where a lack of resources are seen. These countries could be targeted for more for research because they lack the basic resources. So they need this, so they will sign up. And that happens in some countries. Those with perceived limited resources might be treated differently than those with perceived abundant resources in various ways. So let's move on to the racial disparity category, and just a notable mention of a few atrocities due to disparity in research under this category. And we've all heard these before, but I think it's important to mention them. The Tuskegee syphilis trial, which occurred in 1932. We all know what happened there with men who were not treated for syphilis, not told they had it. And just to see what would happen. And 42 years later, the families were awarded some of the damages and were given an apology. So not to go into so much detail, but that was horrible. Another one was the Henrietta Lacks immortal HeLa cells. It wasn't actually a trial, but it involved her cells were donated for scientific research without her consent and used over and over and over for years, and are still being used today. Actually, I think the latest some were used for COVID research, and the family did not have knowledge of this, and her name was sold to media outlets, no consent at all. And the good thing that came out of this was that millions of people benefited from their cells, which were unique. But we've learned from that. Now we ask for consent for specimens that are going to be used for future research. We don't do this without consent. And back then, it was not illegal, but unethical. And the Auschwitz, Germany human experiments, which was not research at all, but unethical treatment and abuse of humans. Horrible atrocities occurred. Now, we can't rewrite history, we know this, but we can remember the suffering of innocent people and abuse, and we can change the future. So that's what we are doing today with research. Now, another example of racial disparity was cited in a 2021 peer-reviewed article in the eLife Journal. This article cited a groundbreaking analysis of NIH grant success revealed in 2011 that grant applications submitted to the NIH, National Institute of Health, by the United States, in the United States by African-American or Black principal investigators are less likely to be funded than applications submitted by white PIs. And efforts to narrow this funding gap have not been successful. A follow-up study it was in 2019, showed that this had not changed at that time. So obviously this needs to end, and it needs to be discussed and examined. As far as gender goes, we all know that women are underrepresented in research, which tends to focus more on men. And studies need to include more women because our data is valuable to research. And I think some studies are starting to try to trend more to that, to be more inclusive of women. As far as educational disparities go, those with higher education may be selected to participate in research versus those with learning challenges, as I mentioned before, who are, this group is often overlooked and or not even enrolled, which is absolutely unfair. The ability to explain research in layman's terms while avoiding oversimplification or being condescending is very important. We just can't make assumptions about a participant's intelligence. That should be avoided. Again, encourage questions and ask often to determine understanding. This is not just at the consent phase, but all throughout the trial, to make sure that participants understand the process that they have enrolled in. Now, a situation that could set the foundation for disparity involves representation, something else to think about. In other words, who do people see when they are presented with the research? We should try to have people, when we're building our teams, with similar qualities as individuals that are to be recruited. Not always possible, but it should at least be an effort. So if we're recruiting from certain populations, have someone on the research team that reflects similar characteristics, but not just in physical presence, someone who can actually relate to that group. For instance, the LGBTQ plus group, maybe try to have someone on the team that can relate to that population or maybe has that characteristic, or different cultures or genders. If you are recruiting all women for research, it might be a good idea to have some women on that research team. I think that's really important. Another example of disparities involves research in institutions of higher learning. According to an article written in MSU Today in February 2021, university researchers from minority groups are more likely to feel undervalued. The article reads, a small portion of the article reads, a multi-institutional team of researchers, including Michigan State University social scientists, has been granted over $800,000 from the National Science Foundation to study epistemic exclusion. This type of exclusion results from policies and practices within American institutions of higher education that make minority faculty members in STEM fields feel that they are unsupported and their research is undervalued. Now, obviously, this behavior needs more discussion and should be disrupted, because everybody has something to contribute, and this just should not be in place. So now we're going to watch a video. We didn't ask everybody to bring popcorn, but we're going to watch a video that demonstrates how disparities in research can occur in other countries. I hope you can see it. Can everybody hear?
I can
Okay.
Yes.
Yes.
Okay, thank you.
I'd like to share with you the story of one of my patients called Celine. Celine is a housewife and lives in a rural district of Cameroon in West Central Africa. 6 years ago, at the time of her HIV diagnosis, she was recruited to participate in a clinical trial which was running in her health district at the time. When I first met Celine a little over a year ago, she had gone for 18 months without any antiretroviral therapy, and she was very ill. She told me that she stopped coming to the clinic when the trial ended because she had no money for the bus fare and was too ill to walk the 35-kilometer distance. Now, during the clinical trial, she had been given all her antiretroviral drugs free of charge, and her transportation cost had been covered by the research funds. All of these ended once the trial was completed, leaving Celine with no alternatives. She was unable to tell me the names of the drugs she'd received during the trial, or even what the trial had been about. I didn't bother to ask her what the results of the trial were, because it seemed obvious to me that she would have no clue. Yet what puzzled me most was Celine had given her informed consent to be a part of this trial, yet she clearly did not understand the implications of being a participant or what would happen to her once the trial had been completed. Now, I have shared this story with you as an example of what can happen to participants in a clinical trial when it is poorly conducted. Maybe this particular trial yielded exciting results. Maybe it even got published in a high-profile scientific journal. Maybe it would inform clinicians around the world on how to improve on the clinical management of HIV patients. But it would have done so at a price to hundreds of patients who, like Celine, were left to their own devices once the research had been completed. I do not stand here today to suggest in any way that conducting HIV clinical trials in developing countries is bad. On the contrary, clinical trials are extremely useful tools and are much needed to address the burden of disease in developing countries. However, the inequalities that exist between richer countries and developing countries in terms of funding pose a real risk for exploitation, especially in a context of externally funded research. Sadly enough, the fact remains that a lot of the studies that are conducted in developing countries could never be authorized in the richer countries which fund the research. I'm sure you must be asking yourselves what makes developing countries, especially those in sub-Saharan Africa, so attractive for these HIV clinical trials. Well, in order for a clinical trial to generate valid and widely applicable results, they need to be conducted with large numbers of study participants, and preferably on a population with a high incidence of new HIV infections. Sub-Saharan Africa largely fits this description, with 22 million people living with HIV, an estimated 70% of the 30 million people who are infected worldwide. Also, research within the continent is a lot easier to conduct due to widespread poverty, endemic diseases, and inadequate healthcare systems. A clinical trial that is considered to be potentially beneficial to the population is more likely to be authorized, and in the absence of good healthcare systems, almost any offer of medical assistance is accepted as better than nothing. Even more problematic reasons include lower risk of litigation, less rigorous ethical reviews, and populations that are willing to participate in almost any study that hints at a cure. As funding for HIV research increases in developing countries and ethical review in richer countries become more strict, you can see why this context becomes very, very attractive. The high prevalence of HIV drives researchers to conduct research that is sometimes scientifically acceptable, but on many levels ethically questionable. How then can we ensure that in our search for the cure, we do not take an unfair advantage of those who are already most affected by the pandemic? I invite you to consider 4 areas I think we can focus on in order to improve the way in which things are done. The first of these is informed consent. Now, in order for a clinical trial to be considered ethically acceptable, participants must be given the relevant information in a way in which they can understand and must freely consent to participate in the trial. This is especially important in developing countries where a lot of participants consent to research because they believe it is the only way in which they can receive medical care or other benefits. Consent procedures that are used in richer countries are often inappropriate or ineffective in a lot of developing countries. For example, it is counterintuitive to have an illiterate study participant like Celine sign a lengthy consent form that they are unable to read, let alone understand. Local communities need to be more involved in establishing the criteria for recruiting participants in clinical trials, as well as the incentives for participation. The information in these trials needs to be given to the potential participants in linguistically and culturally acceptable formats. The second point I would like for you to consider is the standard of care that is provided to participants within any clinical trial. Now, this is subject to a lot of debate and controversy. Should the control group in a clinical trial be given the best current treatment which is available anywhere in the world? Or should they be given an alternative standard of care, such as the best current treatment available in the country in which the research is being conducted? Is it fair to evaluate a treatment regimen which may not be affordable or accessible to the study participants once the research has been completed? Now, in a situation where the best current treatment is inexpensive and simple to deliver, the answer is straightforward. However, the best current treatment available anywhere in the world is often very difficult to provide in developing countries. It is important to assess the potential risk and benefits of the standard of care which is to be provided to participants in any clinical trial and establish one which is relevant for the study, for the context of the study, and most beneficial for the participants within the study. That brings us to the third point I want you to think about: the ethical review of research. An effective system for reviewing the ethical suitability of clinical trials is primordial to safeguard participants within any clinical trial. Unfortunately, this is often lacking or inefficient in a lot of developing countries. Local governments need to set up effective systems for reviewing the ethical issues around the clinical trials which are authorized in different developing countries. And they need to do this by setting up ethical review committees that are independent of the government and research sponsors. Public accountability needs to be promoted through transparency and independent review by non-governmental and international organizations as appropriate. The final point I would like for you to consider tonight is what happens to participants in a clinical trial once the research has been completed. I think it is absolutely wrong for research to begin in the first place without a clear plan for what would happen to the participants once the trial has ended. Now, researchers need to make every effort to ensure that an intervention that has been shown to be beneficial during a clinical trial is as accessible to the participants of the trial once the trial has been completed. In addition, they should be able to consider the possibility of introducing and maintaining effective treatments in the wider community once the trial ends. If for any reason they feel that this might not be possible, then I think they should have to ethically justify why the clinical trial should be conducted in the first place. Now, fortunately for Celine, our meeting did not end in my office. I was able to get her enrolled into a free HIV treatment program closer to her home and with a support group to help her cope. Her story has a positive ending, but there are thousands of others in similar situations who are much less fortunate. Although she may not know this, my encounter with Celine has completely changed the way in which I view HIV clinical trials in developing countries and made me even more determined to be part of the movement to change the way in which things are done. I believe that every single person listening to me tonight can be part of that change. If you're a researcher, I hold you to a higher standard of moral conscience to remain ethical in your research and not compromise human welfare in your search for answers. If you work for a funding agency or pharmaceutical company, I challenge you to hold your employers to fund research that is ethically sound. If you come from a developing country like myself, I urge you to hold your government to a more thorough review of the clinical trials which are authorized in your country. Yes, there is a need for us to find a cure for HIV, to find an effective vaccine for malaria, to find a diagnostic tool that works for TB, but I believe that we owe it to those who willingly and selflessly consent to participate in these clinical trials to do this in a humane way. Thank you.
So I think Ayanna has or we might have lost her.
I think she's
Okay.
having some difficulties.
Oh, okay. Well, I'll go ahead. This message, she said it very well. It's a message that says that we should all be mindful that when the study ends or prior to the study ending, we have to make sure that the participants have access to approved treatment. And we have done this at our site with one of our studies where we had children on. The drug had been approved. It's a new drug called, Biktarvy. And we had to absolutely make sure that the insurance was in place, the coverage was in place so that they had access to the drug when the trial ended. So it was a smooth transition and no one was left without the drug. Okay, so we're going to go to the next slide. So let's talk about distrust. What about it? These are just some surveys. Can everybody see the slide? Okay. So a 2017 survey by the Pew Research Center found that only 37% of Americans have a great deal or quite a lot of confidence in medical scientists to act in the public's best interest. This survey also mentioned that the level of confidence was lower than for many other groups like the military, scientists in other fields, and religious leaders. In 2019, a study published in JAMA Oncology found that among cancer patients, only 43%, less than half, reported having a good understanding of clinical trials. This study also found that those patients who reported having a better understanding of clinical trials were more likely to consider participating in them, which makes sense. A 2020 survey by the National Cancer Institute found that about 1/3 of the United States population expressed concerns about participating in clinical trials. The most common reasons for not participating were, and we probably can guess what these are, concerns about side effects, lack of trust in the medical system, and fear of being a guinea pig. I want to circle back and just say that the medical system is not just physicians, okay? It's all of us. It includes the person that the patient meets when they walk into the facility or clinic, all of the interactions that they have, all the way up to the physician, including the physician, and then every person that they have in contact with as they walk out of the facility. So we all have jobs to do to help improve the trust that people have in our systems. A 2021 survey by the nonprofit organization CIS-CRP, which stands for Center for Information and Study on Clinical Research Participation, found that while 84% of Americans are willing to participate in a clinical trial, if recommended by their doctor, only 19% have actually participated in one. The group also found that lack of trust in the medical system, again, that's all of us, was a major barrier to participation. We can see how this happens. Sometimes we'll go in a room, the patient will tell us something and then go out, we leave, the physician goes in, they tell them a completely different thing. I'm not sure why that's bad. Let me put this here. Oops. Okay. We've done that already. Okay. So sometimes that can happen. They might feel more comfortable sharing information with one person versus another. We don't know why, but that's what we suspect. Okay. I don't know if Ayanna's back. We have another poll question.
Yes, I'm back, but I'm on my phone.
Okay.
My computer's acting up today, so I'm
Oh, no.
just,
Okay.
yes, I'm on my phone. So
I'm trying to get the next one. Okay.
Okay.
I think we got it.
Okay. Thank you. So here's one about the definition of vulnerable. True or false? Vulnerable is capable of being physically, emotionally wounded, or open to attack or damage. And we won't cue the Jeopardy music, but you can go ahead and start your answer.
about a minute to answer the question.
Okay. Can you see you can see the poll, Ayanna?
Yes.
Okay, I'm sorry. Okay. I think we're all there. Okay. So, yay, it looks like everybody got it right. Yes, this is true. So in this, according to this definition, we're all vulnerable. Okay. 100%. Good. Okay.
Yay.
Okay, so we'll go on to the next slide.
So can you think of ways to develop trust in research? And this is a question for everyone, and I see some comments are in the chat as well.
Oh, okay. Let's see.
This is a question for you all. You want to chime in?
Yes, that's true. And I see those comments. Yes, that's true. Thank you.
No one can think of anyone.
Oh, Dr. Sikor?
So I'll chime in first. I think the only way is to have a record of ethical behavior. So I think that nothing can quickly change. And I was just going to, I reread about the Tuskegee experiment quickly offline, because my recollection was correct. It was more egregious than I think people realize, because at the time that this experiment was conducted, there was not good treatment, right? There was, syphilis was not easily or effectively treated because it started in 1937. And people were told that first of all, they were lied to. They were told they were getting treatment, and they were not, they were being observed. And then they were told that it was only 6 months, and it went on for 40 years. Then they continued to follow. And then treatment became available, and it was not offered. And this didn't end until 1972. Oh my God, that's like, for the older members of this audience, we were in high school when this egregious thing finally ended. This was within our lifetime. It wasn't. So, and we can all think of things that have happened in our research lives that were ethically soft, or maybe this should have gone this way or should have gone that way. So I think only a long track record can completely and open communication and communication with the clients doing research about what's available. We have to be willing, if we're doing a study and something becomes available, or suddenly it becomes clear that this isn't working, to have that discussion with the clients. That's my 2 cents.
Absolutely. I agree.
I would add transparency and patient safety.
Absolutely.
Yes, absolutely.
Because you can't trust anyone if you feel like something's going to happen to you during the trial and there's no one to rectify or resolve the problem. Yeah, very good.
I think it's also important that the PI communicates with this patient or the family and introduce the staff, the research staff who will be assisting with conducting the research, because the relationship initiates between the physician and the patient. And I think it's important that initially with the study that they're kind of involved and they introduce the staff that's going to be working with them to conduct the study.
That's true.
Yeah, that is
You have to put a face behind the names. Yes, absolutely. Okay.
well, great
Good.
input. And here are some other ways. Being mindful of disparities within research. It's difficult to change what we're not aware of. Learn about different cultures. Bringing diversity and inclusion into research, allowing all spectrums of individuals, and just being honest throughout the study. Respect gender identities by using preferred pronouns and seek clarification if needed. Avoid assumptions, fair equal treatment, and just present non-judgmental approach to the participants.
And also, ways to develop trust would include being honest. We haven't said, I mean, we've said that multiple times, and we know that everybody on this call is. I just want to give a quick story that happened several years ago with a 7-year-old boy who had advanced AIDS. And he had gone through all of the pediatric, the approved medications that were available to us at the time. And, you know, there was no improvement in his condition. So our physician, our PI medical director at the time had to go through the compassionate access program to obtain a drug. And we didn't know, I think it was a 24-hour approval, and then the drug would come. As he waited, his condition continued to deteriorate, and the physician had to be honest with the mom and say, we don't know if this is going to do anything for him, but it's our last effort and we're going to try. If you are, you know, are willing to go through with this. And she said, of course, yes, do whatever you have to do. Well, we got like news from the pharmacist that the drug had arrived. There was a quick, get the drug in, start the infusion, go ahead. But as time went on, his condition continued to deteriorate. It just wasn't in time. And I'll remember this to probably the day I take my last breath. It was in ICU when the mom leaned over to this child, her child. She was inches from his face, and she told him, go to the angels, baby, go to the angels. She was sobbing, and I don't think there was a dry eye in that ICU room. She was giving him permission to let go. He was having labored breathing. He looked like he was struggling to hang on. I think because the physician was honest with that mom, instead of saying, oh, we got a miracle drug coming, this is going to do it, this is going to be it, the thing that saves him, the honesty and compassion gave this mom the courage to release her child to death. And I think that honesty and compassion go a long way. So we can't say enough about this throughout the trial. And it doesn't have to be the life or death situation, but honesty. All right. Always be consistent when it comes to compensating and time management of the study visits. If you say we're giving up $50 in cash, we need to be consistent rather than saying we're going to give cash and then giving something else. Because the person's wondering, okay, well, what else is going to change? And it just makes it a little, a question comes in their mind. Data protection assurance means keeping collected information confidential and anonymous as the research dictates. ID numbers instead of names, under lock and key, filing information securely, all of those things. Avoiding errors. Well, we're all human. And we know that sometimes mistakes will happen, hopefully just minor ones. But when they do happen, we have to admit the mistake, explain to the participant, and rectify and resolve it. Because again, like Dr. Matus, I think that was Dr. Matus saying about safety. Well, that's very important. We have to maintain safety. Be respectful of the participant's time during the visit. So we always give an estimate of the time prior to the visit so that they can make adequate arrangements for childcare, employment obligations, or school obligations. If we say this visit's going to be an hour and a half, then we have to keep it to that. Or maybe this is an all-day visit, 8-hour day. We have to certainly let you know ahead of time so that the participant can be prepared. Developing relationships, I think, is really important. Both of us agree, Ayanna and I, about how this develops trust. So when a participant comes in, or try to get to know maybe their kids' names, so that you can kind of call their kids by their names or get to know something about them. What are your plans for the weekend? If it's around a holiday time, is there a special food that your family enjoys during the holiday, or do you even celebrate this holiday? Just things like that. It makes a person feel like, wow, you're trying to get to know me as a person and I'm not just that guinea pig. Visibility in the community is another thing. It helps to legitimize the work and puts names behind the faces of the researchers. Now, this doesn't always mean getting out to community events, which is also a good thing, but some groups I know can't do that. But if you can, that's a good first thing. Zoom, like we're doing. If a group is having a meeting, maybe you could Skype in and talk to that group about the research, so that the community is aware of what's going on. Lunch and learns are good because people love to commune around food. And it's a great way to just do a quick, this is who we're trying to recruit. These are the criteria. This is why this research is important. And it familiarizes people in the community about it. Okay. So we have another poll question. This is our last one, so you can.
Our last poll question.
Okay. You want to do this one again?
Is the research sponsored? It's the research sponsor's responsibility to make sure the participants have health insurance to gain access to approved treatment. True or false? And we got under a minute to answer. I know the time, we're almost at the 9 o'clock.
Oh, okay.
Hour, so.
Better hurry. Sorry.
Okay, we're going to share our results.
Okay.
If we can share those results.
Okay.
And yes, so 64% said false, 36% says true. It is the site's responsibility to make sure that the health insurance is approved for that treatment.
So this is a
clinical
false.
site. Yeah, so this is
the
false.
answer is false. Yeah.
The answer is false.
Yeah. Oh, I'm sorry. Dr. Secord had a question.
I was just going to say, is there a correct answer to that? Because some studies allow, are doing care or enrolling non-insured persons. So in such an instance, it may be a good thing to try and link the person on with insurance, but not all studies are drug related. Not all studies would require a patient to have insurance.
That's true. I think we were looking at the fact that the sponsor is not intimately aware or has the relationship that we have with the participant. So while they may have the drug is approved and available, in those cases where it's a treatment trial, I think the responsibility lies with the site who has enrolled the participants to make sure that they seek coverage for access to that treatment if they choose to use that drug after the trial is over.
Yeah, I agree that
I
would
think
be
in that
best
way.
practice. Although
So-
remember, like at our site, we're also, for most of our studies, we're also the treating site, and that wouldn't always be true, but it's, I think it's best practice, as you say, for the site to take on that responsibility. It's the most ethical thing.
So
Yes.
that's a good question. All right, so trust is a feeling. The participant might not verbalize distrust, but it may be evident in their behavior by not showing up for scheduled visits or not completing assessments during the trial. So we have to kind of be aware of that and ask questions with the participant during those times. Trust is a feeling of safety from being able to rely upon a person. So in relationship to research, it's no errors, if keeping them to a very minimum, if at all, and answering questions correctly for the participant. Trust is a feeling of confidence when taking thoughtful risk and taking enrolling in a study, especially sometimes with a placebo trial. It is definitely a risk. So in relationship to research, keeping our word gives reassurance that we're competent to conduct the trial and helps build confidence in the participant. Trust is a feeling of clarity from experiencing believable communication. So, like we said before, explaining what is required in a way that is easily understood by the participants. And trust is a feeling of satisfaction from cooperating and experiencing teamwork with a group. So as in the research world as elsewhere, a team approach with the participant as a valuable member of the research team helps this trust to develop. They're not guinea pigs. Well, if they have questions, they need to be able to ask them and feel comfortable with that. So research is critical, and Ayanna and I are proud to be part of such a group as yourselves who are ethical in their treatment, safe in their care, and compassionate in their approach. As you leave today, please continue to protect the vulnerable and stand up against disparities with colleagues and participants. We hope that this presentation has given you more to consider when you're conducting your own research.
Thank you so much for all listening in for our presentation. And do we have any questions? And I know we're
Hi,
at the 9 o'clock hour.
I have actually one comment. First of all, this was excellent. Thank you so much. I sit on the IRB at Wayne and review a lot of protocols. And when I go through the consent forms, that, the shortest one might be about 25 pages. And I was wondering how, how the study team, goes through this consent process with potential participants. And you explained that very well, and I appreciate that. Just going through page by page, because again, I mean, we've had to send back consent forms because the verbiage might have been too technical or, might not be easily understood by most. So I really appreciate that the time and care that you go through each section. And I hope that the other study teams that are out there that are conducting meaningful research are doing the same. So thank you very much.
Oh, thank you.
Thank you.
Yes, we really appreciate our IRB too, because I think we get more of a intense review sometimes, and we're told that, well, the other site, their IRB didn't ask them that question, or I'm like, okay, well, ours is on top of things. So we appreciate that scrutiny.
Are there any other questions from the audience?
I have a real quick question, if you don't mind.
Sure.
So you were talking about gender disparities in research, especially when it comes to men versus women. And I've heard before that there have been actual trials that use the data collected from men to talk about the women. Could you talk a little bit about that? Is that true?
Yes, we had one study that I can recall that was it approved this drug. There was a drug called Biktarvy, and in the trial nationally, they predominantly had men on this adult trial, and they discovered that they needed more women because there was a lack of women, and they wanted to see what this drug, how this drug was. I don't know. I don't know. I think it was the efficacy, but they wanted to see how women responded to this drug. And so we had to actually recruit women specifically for the trial. And I still don't know the results of that study yet. It's been maybe 3 or 4 years now. I mean, I'm sure the results have been published. But yeah, is that Dr. Secor, did you have a?
I think more commonly, what you're describing is true, but more commonly in our world, and I think probably in other research endeavors, that studies are conducted primarily with men, because they don't want to have women of childbearing age in the study because it complicates the data, but it also complicates life because then you can't use drugs in women of childbearing age because there are differences. So now I think there's, at least in the HIV world, there's more of a concerted effort to include women in these studies. And I can't speak to, oncology and diabetes and other worlds, but at least in our world, I think there's been an outcry that you can't conduct studies just with men and then extrapolate to women.
Thank you so
And
much.
at least recently, the FDA won't approve medications for certain indications if there aren't women included. For example, Disparity is not approved for use among women as PrEP because the studies didn't include women. So
yeah, that's true. Thank you.
Thank you.
Thank you, everybody. All right, so we are a little bit past time. I want to again thank our presenters so much. This was great information. And everybody have a great day. Thank you.